importance of the meniscus in the knee joint is now commonly understood, and all major orthopedic societies recommended preservation of the meniscus. While suturing of the meniscus tear is the most common surgical technique, it has limited indications. The best results are obtained by suturing a simple type of tear in the red and just satisfactory in the red-white zone respectively. The results of meniscus suturing in the white zone are far less successful. In recent years, there has been a growing trend in the use of biological factors to enhance regeneration and tissue healing of meniscus lesions. One of these strategies includes the new surgical technique of arthroscopic matrix-based meniscus repair (AMMR) using a collagen membrane accompanied by bone marrow blood aspirate injection. AMMR is an evolution of Henning's concept to create a biological compartment with an optimal alignment of meniscus healing. Originally, the meniscus lesions was sutured and wrapped with periosteum from the pes and the sinus region. This was later replaced by collagen type 1 matrix produced from portion peritoneum. Initial results were satisfactory, but it was technically difficult, and outcomes were not reproducible. Therefore, a new simplified, quick and safe technique AMMR has been developed and will be presented. In this surgical technique video, we are going to present a 19-year-old female patient with medial meniscus injury of the right knee joint. She was presented with intermittent pain of the knee joint, increasing over the last 12 months, limiting her sports activity. She reported twisting knee injury 1 year ago. Subjective examination reveals slight swelling of the knee joint line tenderness, locking, and a positive McMurray test. The IKDC score 52 points and Lisholm score 64 points. The medial meniscus with a combined horizontal tear injury can be seen on the preoperative MRI of the right knee joint. This video footage will demonstrate the currently used surgical technique of AMMR. Patient is placed in the standard operating position of the arthroscopic knee surgery. Portals location are marked. There is no difference in location of portals for medial or lateral meniscus surgery. The surgery can be performed using standard arthroscopic instrumentation and the collagen matrix chondrocyte manufactured by Geistlich Pharma. This is the only medical device with CE mark registered for the type of meniscus treatment. This is an intraoperative arthroscopic video of one of our recent patients diagnosed with the horizontal tear of the medial meniscus and unstable meniscus. The Hoffa's fat pad may need to be partially removed if its presence hinders access to the menisci. Depending on the tightness of the knee joint, some release procedures may be necessary at proximal or and distal part. If the surgery is limited to the meniscus treatment, usually the release on the femoral part are enough. Lateral compartment is enlarged by release of iliotibial band by horizontal cut, and standard MCL release techniques are used for extending the medial compartment. Care is taken not to over-release, leading to the joint instability. Firstly, the meniscal lesion is reduced and stabilized by meniscal suture. Any type of stable meniscal suturing techniques can be used. It is operating surgeon decision where inside out, outside in, or all inside sutures is used for meniscal tear stabilization. I use inside out suturing technique and additional stabilization with fast fix. In the AMMR technique, the collagen matrix chondrocyte is used for meniscal wrapping. We routinely use out-of-the-box piece of the membrane 2 by 3 cm. In the very rare occasion, size 3 by 4 is used. No additional trimming is necessary. We have developed the dedicated inserter instrument to make the process of membrane insertion quick and easy. The collagen membrane is mounted on the gold inserter with the porous surface forward. The instrument is then ready to be placed inside of the knee joint. korzy. The collagen membrane chondroguide is introduced into the knee joint with the help of the insertion instrument, goat forceps, and positioned around the previously stabilized meniscus. The stabilized meniscus is wrapped in the collagen membrane. With the insertion instrument still in place, the membrane is fixed to the meniscus body. Fix the chondroguide membrane and the meniscal posterior horn using a fast fix or cinch tool, and then continue with other inside out, outside in, or all inside, not absorbable meniscus stitches. After membrane is firmly secured in its required position, the final positioning and alignment of the membrane can be performed by using the arthroscopic probe. The membrane should cover femoral and tibial meniscal surfaces in the uniformed fashion. Some wrinkling of the membrane is allowed and does not affect the healing process. In the final step of the procedure, the biological factors can be added. We are obtaining the bone marrow blood intra-articularly from femoral condyles next to the femoral insertion of the posterior or anterior cruciate ligaments. In this patient, the bone marrow aspirate was injected between the meniscus and wrapped collagen membrane for enhancing the healing process. If the bone marrow aspirate cannot be obtained, the intra-articular microfractures or the medial or lateral femoral condyles can be performed, allowing bone marrow blood entering the joint space. A last look at the stabilized and wrapped meniscus ends the surgery. Post-operative physiotherapy regime is similar as for patients treated with simple meniscus fixation. However, an individual approach depending on the meniscus injury type and the location is recommended. For most of the cases, it is recommended to restrict load bearing during the first 2 weeks after surgery and then progressively increase load bearing and knee flexion up to 120 degrees during week 3 and 4. For patients undergoing medial collateral ligament release, wearing a knee brace is indicated for 2 weeks. It is expected that patients will return to regular weight bearing and full recovery with full knee flexion within 5 to 6 weeks after the AMMR surgical treatment. Clinical results of meniscal tears treatment using AMMR method are very good. Here is an example of a 5 years post-operative follow-up on one of our patients with a medial meniscus injury. The horizontal meniscal tear extended to the posterior horn and was further complicated by a radial tear. This patient was symptoms-free directly after surgery and has not had any knee symptoms since. The AKDC and Lisholm scores were 92 and 94 points respectively. The 5 years post-operative MRI shows a correctly shaped meniscus with no signs of extrusion or any cartilage damage. Visible scars inside of the medial meniscus body are most likely a result of the meniscus suturing and tissue healing processes. This video demonstrated a surgical technique of the arthroscopic matrix-based meniscus repair, also called AMMR, using a collagen membrane accompanied by bone marrow blood aspirate injection. This surgical treatment offers alternative therapy for patients with meniscal injury should it otherwise for total or partial meniscectomies. The method is safe and relatively straightforward. The patient reported and clinical outcomes of patients treated with AMMR technique after 2 and 5 years are very good and sustainable. This surgical method was developed to extend the treatment options for the surgeons treating patients with meniscus injuries to preserve the native meniscus and to meet the paradigm save the meniscus. Thank you very much for your attention.